couple of seconds, Thevikum.
Yeah, sure.
All right, go for it.
Good morning, everyone. I'm Thevikum, and my research is to evaluating left anterior descending coronary artery dose, tolerance, and constraints in left breast cancer DIBH patients. My supervisors are Dr. Pejman, Mr. Milad, and Dr. J. Kenrick. And first, I will introduce myself a little bit. Currently, UW have two Master of Medical Physics Masters, Master of Medical Physics and Master of Physics. And last year, they started Master of Medical Physics. That's what I'm studying. And I am the first international student. For me, I have only 4 research units compared to Master of Physics, which 6 units. I'm going to do the literature review research. So first, this is the method that I'm going to conduct my research using some databases and engines and using the, special keywords, going to find out the articles between 2014 to 2024 and gather the data from different kind of technique and receive LADCA doses. And then finally, I'm going to find out the ideal LADCA dose tolerance values. Currently, I found 1,233 publication and need to be screened out. Here, first we discuss about the breast cancers. Breast cancers are basically made up of lobulous and duct and fatty and connective tissues. Normally, breast cancers develop at any age, but there's a high probability of it's getting when we're getting older. We are getting breast cancers, and for the both men and women, both left and right breast has probability of getting breast cancers, but higher risk of higher probability of getting breast cancer for the women's. And this is the second most commonly diagnosed cancer in 2022. According to Cancer Australian website, it shows there's more than 20,000 of cases was found in for the breast cancers in 2022. So next talk about the lymphatic system. So lymphatic nodes are very small rounded glands that can found and it's helped to protect the body from the infections. Basically, there are 3 regions of the lymphatic nodes. We can see armpit and supravascular node and internal mammary gland. Why this is important? It's often the first place where the breast cancers is going to spread, and when we treating for the breast cancers, mostly we treated with these 3 regions especially. And when considered 1 on 3 women with breast cancers have found that breast cancers have in lymph node in their armpit region. Okay, so how the breast cancers develop is normally abnormal of breast abnormal cells. It start from the duct or lobulus, and it's the known as the primary cancer. So there's 2 type of breast cancers. Is non-invasive and invasive. What's non-invasive? That it stay in the duct and lobulus, that not going to spread, and it's the basic cancer. But invasive is the advanced and secondary cancer. It's going to spread through the whole surrounding tissues by using the lymphatic system. And there's the few statistics that found for the breast diagnostic breast and the death that occurred in 2018 to 2022. And we can see there's a high probability of getting breast cancer for the women's, and there's there's a high probability of getting death in because of the breast cancer in the women's. So in this graph shows the number of cases with males and females from 1982 to 2017. We can see for the males, there is no significant difference for the breast cancer patients for the males, but for the females, is gradually increased during the whole from 1982 to 2020. I'm going to explain a little bit about the cardiac toxicity, because when we treat for the radiation for the breast cancer, it exposure to tissues and complex organ such as myocardium, pericardium, blood vessels, lymphatic vessels, and nerves, as shown in this image. So what happened? Radiation exposure to this organ at risk, it will cause cardiac adverse event. Is major cardiac adverse event are ischemic heart diseases, pericarditis, congestive heart failure, valvular diseases, and arrhythmia. Even for the low doses of radiation exposed to the heart, it can increase the ischemic heart doses. Also, in clinically, currently they use a threshold for 3 to 5 gray of mean heart doses for treating the breast cancers. So why I'm going to focus on the left anterior descending coronary artery. The reason is especially location is anterior to the heart and increase the major coronary vein with the increase of mean heart dose. The morbidity and mortalities are as ischemic heart disease, that means lack of the oxygen, and due to the lack of blood supply can cause death, coronary revascularizations, and myocardial infractions. Here's that I found publications of doing that using 8 megavolt photons and 6 megavolt photons treatment for both left and right breast cancers. We can see the right breast cancer treatment, and here in left anterior descending coronary artery showed in a red dot. We can see when the right breast cancer treatment, so it doesn't expose the heart much of volume, and also it doesn't expose to the LADCA in right breast cancers. But when treating for the left breast cancers, it exposes to the LADCA also, left ventricle, and within this dose color map, we can see is higher doses is exposure to the LADCA. That's why we are going to focus on LADCA especially. And for treating for the reducing LADCA for the breast cancer, there are few methods like DIBH, photon therapy, VMAT, IMRT, and novel technologies, proton therapies. So what we need to focus on here is that each type of patient, when we treating, is a breast and chest all are different. So when the treatment planning, we have to consider the patient's anatomy. And this is one of another publications that I found from Bradley. Is what he done is he uses 4 type of techniques: 3D CRT, IMRT, VMAT, and double scattering. Is only he used 3D CRT with DIBH. We can see without DIBH, is in novel technologies, they could reduce the mean heart dose for the LADCA, but what is the importance of DIBH in here is even for the less advanced technology like 3D CRT, it could reduce the heart 5-gray heart exposure volume to 14% for even when we use in the novel technology, it's increased the heart exposure using this IMRT and VMAT technique, so that it specify the importance of DIBH using in the treatment. And double scattering gives promising result for volumes exposure and the LADCA dose, but because of the limitations and the complexity, there is not availability, they don't use proton plant therapy in the left breast cancer patients. So in this low publications, they could delineate the high risk cardiac zone in blue color and LADCA in the red dose. So what they done, this acceptable autosegmentation performance in 3 centimeters to 4 centimeters, as we can see in the image. And this is one of the important images that 3D images, that 3-dimensional representation that are done for 3.5 centimeter to wide high risk cardiac zone is shown in the blue color, and this is the red LADCA shows in the red. So next we'll discuss about the main topic, the DIBH. How it's important. Deep inspiration breath hold technique is a technique that patients have to take deep breath to 20 to 30 seconds during their delivery treatment. So what happens when they take deep breath is the distance between the heart and chest wall increases. So it can minimize radiation exposure to the healthy tissues, and we can use DIBH for the breast cancers, lung cancers, and liver cancer treatment. And here's another publications that shows the importance of DIBH compared to the free breathing technique. When using the free breathing, radiation exposure to the heart is increased. But when you're using the DIBH technique, it could avoid or minimize the heart doses from the radiation. So what are the importance of DIBH? When patients take a deep breath, when they hold, the respiratory movement we can reduce the movement of respiratory. So we can improve the tumor targeting, improve patient outcome, and we can improve, prevent the long-term side effect. Also maintaining good therapeutic index, that's the main goal of radiotherapy, and minimize the radiation to the organ at risk. So there are main three types of DIBH technique available: active breath controlling, voluntary breath hold technique, and surface guide radiation therapy. Active breathing control is a technique that use devices such as this Electa ABC and images shown in here. What they're doing is that they connect this device through mouthpiece to the patient, and put a clip in nose that patient can't take breath voluntarily. The machine device control the patient breath and hold their breath in a specific lung volume, such as in a gating window. It shows in this images. When the breath lung volume is in the prescribed volume, like in the green window, they treat in the patient, and if the breath lung volume change, it will shut down the machine. It prevent the causes radiation to the heart. And the voluntary breath hold technique is the patient has to take voluntary hold in the breath. So he has to practice it in the clinical and also practice from the home. So it's also very comfortable for the patient, like not active breath controlling. But the thing is, when we doing the treatment planning and treatment, maybe it's different because the voluntary breath hold technique is like patient doing it's voluntary, so lung volume may be quite different from sometimes. So the service guide radiation therapy is the novel technologies. SGRT that shows in this image is the catalyst SGRT setup and the Helicon machines. What they're doing is with these three machine scanners, they scan the patient body surfaces and they measure the position of patient and send the details to the machine, correct patient location. Also using the gating technique, they treat the patient with the correct lung volume and giving promising results. So this is the one of meta-analysis. It was free breathing. They found out that LADCA was 1.45 from the 12 observation, and this is other publications that they use. And this is DIBH was a deep breathing technique. What they have done is they use DIBH technique and measure the dose of the mean heart doses and the full respiration cycle, divide into 10 cycle, measure the start lung expansion and the middle start lung expansion and middle lung expansion, and they measure the radiation doses to the heart in both two positions. What they found is DIBH gives lower doses compared to this SLE and MLE. And finally, this is my timeline. I'm hoping to finish my research in next year, this November. And my objective is to find out the ideal dose tolerance for the LADCA. Ethics, for my research, I'm not going to approve required for the ethics because I'm not going to involve human and animal subjects. And these are the references that I use for my using. Thank you, everyone. And I need to thank you, my supervisors, for guiding me through this process. Thank you.
Excellent. Thanks, Thevikum. We'll open up for any questions now. See, okay, Mashid, have your hand up.
Yes, thank you. Thevikum, this was a very nice presentation. Thanks for that. If you go back to slide 13 for me, please.
Yeah.
Yes, so here you have mentioned the 3D CRT with the DIBH and then IMRT and VMAT. So I would say the IMRT and VMAT are not with breath hold, right?
Yeah.
Okay, so what we do here in our center and in several centers is we perform the IMRT and VMAT with breath hold, with the DIBH.
No, only the 3D CRT
No.
With the DIBH. This is IMRT alone and
Yes,
VMAT alone.
I understand, but what I'm saying is now it's quite a common practice to do IMRT and VMAT with breath hold. So that improves your outcome.
That's true.
Okay, so that's something that you could search on and add to your work, which would be great. Then slide 18. Yes, so here you have nicely explained about the breath hold, but you mentioned that in the DIBH, if patient holds breath differently on treatment, then it will be different. So what happens nowadays in breath hold is the machine, if the patient holds breath differently, so there is a margin and there is a marker which shows you, we use to see like how the patient is holding breath. So if patient is breathing too differently, like outside the margins for treatment, the beam is automatically cut. And that's the variant setup. So it's not like you're adding too much uncertainty when you're doing DIBH treatments. And if you would like to observe one of our patient treatments, let us know and we can take you downstairs so that you understand how it works. Okay.
Thank you very much.
No worries. Well done.
Thank you very much.
Thank you, Mashid. Ashley, Sean.
Thanks for the presentation, Thevikum.
Thank you.
My question is, so do you think real-time tumor tracking could like further improve this? What are your opinions on that?
Yeah, for the like SGRT, like real-time, for the real-time surface technique like SGRT, it can give promising result as I see the publications. When I read it, I found out that because of these technologies, they like measure the patient's position with 3D, so they know it is within the gated, and it's because of the real time, they can like change radiation, like reduce the radiation exposure to the OAR.
Have you also read on like MRI guided radiotherapy or those kinds of real-time like other modalities in addition to this?
Actually, currently I didn't found with that one, but yeah, I will look into that.
Okay, all good. Thanks.
Thank you very much.
Thanks, Ashley. Thevikum, I might ask a question as well.
Yeah.
So is your plan to conduct a systematic review? I assume that it is based on the Prisma diagram that you showed at the beginning. And if so, what scientific databases do you plan on searching?
Here. Normally I use like PubMed, Web of Science, Science Direct, and Google Search. That currently I just found the publications.
Okay, and your inclusion criteria is meta-analyses, systematic reviews, basically almost any studies conducted.
Yes. Yeah, I found it like meta-analysis and literature reviews also.
Right. Are you going to be conducting your own meta-analysis, or is it just going to be a systematic review?
Yeah, I'm planning to do find out the article based on systematic review and experimental and observations also. And still that I found like a lot of publications regarding these keywords. Like I need to like screen out to find out the systematic reviews also.
Sure. Yeah. So if you are planning on conducting your own meta-analysis, you may need to tighten these inclusion criteria for your studies, but that's something that we can discuss.
Yeah, surely.
All right. Thanks, Thevikum.
Thank you
Good
very much.
presentation.
Thank you.
Okay, stop the recording if you just want